Thanks. This is Anant, and I will now be steering the next section of today's event. First of all, thank you to all our fabulous speakers, Anisha, Victor, and Sonaksha, for the previous very interesting discussion, and of course, Patty for moderating it. So, as you know, this section now focuses on community mental health work, and this is something, of course, which is deeply connected to the work Sangath has been doing for the last 25 years. In fact, in many ways, Sangath, I think, was set up in a way to respond to the needs for developing more models of community mental health work. Of course, working closely with the health system. But Sangath's work is, of course, not alone in this domain. There's been a lot of work which has happened all across the country. And we thought when we were setting up the event for today that it would be really important to highlight a lot of the key learnings from the lot of work which has happened in this space in India over the last many, many years. And speak to a few of our colleagues who, of course, have been innovators, pathbreakers in this domain. Of course, work can never be a complete success. There are challenges which we should talk about. There are barriers that we need to talk about. There are system level barriers. There are perhaps personal related barriers. There are issues around how to keep work in the community mental health space sustainable. So to ensure that we have a discussion which will probably be able to cover all of those components, we have set up again a very widely experienced but also very relevant panel, and it's my honor, of course, to introduce the panel for the discussion for this part. So joining us today for this panel will be Dr. Soumitra Pathare. Soumitra, of course, is a good friend of Sangath. He's the director of the Center for Mental Health Law and Policy at the Indian Law Society, which is in Pune. He has contributed extensively to many policy formulations, including the WHO Mental Health Policy and Service Guidance Package. He has worked as a consultant in many countries across the world in assisting them in developing mental health policy and drafting and implementing mental health legislation. He was, of course, a key player in India's own mental health law, which was formulated, and he worked with the ministry and some key members of civil society in setting it up. And he was, of course, a member of the policy group appointed by the MHFW to draft the then new national mental health policy for India. So thanks, Soumitra, for joining. Also joining us today from the Banyan, also joining us today is Sadam. Sadam, okay, all right. Sorry, I have slides and I have some notes, so we are sort of, going in between that. But let's stay with Sadam. So Sadam is also a very good friend of Sangath. Sadam Hanjabam is the founder and chief functionary of You All Northeast, which is Northeast India's first registered youth queer-led organization. They are based in Imphal. He has been recently enlisted among 6 LGBTQ plus youths to look out for by the United Nations Girls Education Initiative. He was also included among the 10 leaders who can inspire you to change the world by the United Nations Envoy on Youth for its IDA HOBIT 2020 edition. And he was also conferred with the COVID Soldier Award 2020 by Better India. Welcome, Sadam. Thank you for joining. And Sadam will actually be staying on with us for the next panel as well. Joining us also are 2 colleagues from the Banyan, Professor K.V. Kishore Kumar and Mrinalini Ravi. Professor Kumar is a psychiatrist and the director of Banyan India. His areas of interest include community models for mental health care, health promotion using a life skills approach, initiation of community-based detox programs, and stress management for lawmakers. And lastly, training also for mental health workers, integrating mental health care into general health care. Welcome, Professor Kumar. Mrinalini is the co-lead for the Sundaram Fastner Center for Social Action and Research at the Banyan Academy, and she's also the Deputy Director for Partnerships at the Banyan. She holds bachelor's and master's degrees in psychology and mental services research, and she's held, of course, several portfolios in the past decade. But what is closest to her heart is her 5-year stint in managing a shelter for homeless men with mental health issues. Welcome, Mrinalini. Thank you for joining us. Last but not least, we are also joined by our colleague Bindiya. Bindiya is a staff member at Sangath. She has been with us for more than 14 years. So Bindiya Chodankar, through a journey with Sangath. She started off as a counselor and then went on to become an intervention supervisor and field coordinator. Bindiya has extensive work experience in dealing with people with stress, with anxiety, depression, alcohol use disorders, adolescent mental health, and right now is also involved in providing mental health counseling through Sangath's toll-free well-being center, which we set up in response to the needs which were quite apparent to all of us during the pandemic for the need for mental health support, which would be free for the community. So thank you, Bindiya, as well for joining us. Unfortunately, we are not able to be joined by Dr. Ajay Chauhan, who works with the government of Gujarat, is the superintendent of the mental health institute in Ahmedabad, and he was called away for an important meeting. So we will be missing him, but I'm sure there'll be other occasions to engage with Ajay. So I'll start off perhaps with a round of questions, and then that will allow us to set the stage. And maybe I'll ask Soumitra to go first. Soumitra, you've now worked in the mental health sector for many years as a psychiatrist, but then also someone who set up an institute, a center for mental health law and policy, have partnered with a lot of non-governmental organizations and, of course, the government. So what, in your opinion, historically has been the role of non-governmental organizations, community-based organizations in improving the reach of mental health services in communities in India? And what have been the pathways for all of these NGOs and CBOs to work with the health systems? What have been the challenges? What have been the enablers? And what would be, in your opinion, successes in this regard? Soumitra? Soumitra, I don't think we are able to hear you. Can you just try fixing your microphone?
Maybe you can hear me now.
Perfect. Yes.
Yeah. Okay.
Thank you, Soumitra. Go ahead.
I don't know why this happens, but it happens all the time. I was saying that this is not one question. This is like 7 or 8 questions bundled into one. I even lost track of how many of them were there and what the next questions were. But broadly, just two broad observations really, which kind of pertain to most of your questions. One is that the non-governmental organizations or civil society organizations have largely demonstrated a whole range of models of care which are low cost, sustainable, and can be scaled up to large populations. But I don't think that anyone ever claims or will ever believe, anyone who works in the CSO space themselves will know that the CSO space is not a replacement for government action and for public health services to actually do that. So really, what NGOs and CSOs like Sangath or us or even Banyan can really do is to actually show that here is a way of doing things which works, which is low cost, which is sustainable, and which actually meets the needs of people. But the issue is really that people in the government sector need to pick that up from where they've seen what the NGOs are doing. Now that's where the real problem comes from. Unfortunately, that has not happened. The translation of these models of care from the NGO space into public health services has really not happened. It almost seems like the public health services and the NGO services run on 2 parallel tracks in 2 different worlds. And there hasn't been that kind of cross-fertilization that you would expect to happen. That's one. The second thing is that, and this is the second point, is also a criticism of some of the NGO work that we do, as well as also of the public health services. That unfortunately, especially the public health services, take an extremely biomedical approach to mental health, which is purely seeing it as a health issue in the way that you would see other things like malaria, tuberculosis, diabetes, hypertension as purely health issues. When we know enough now from a lot of research from India as well as from across the world, that actually the social determinants of mental health have a much larger impact on people's mental health and their recovery from mental health. And this is not some new discovery we've made. This is something we've known for like close to 100, 200 years now. But you see, the public health services just do not pay any attention to that at all. And that is also true of many of the NGO services. A lot of the NGO work, barring a few of the organizations, tends to focus purely on seeing mental health as a pure health issue and trying to intervene on those health issues. And that really is a problem. I mean, I think these are the two main issues that governments haven't really picked up on these innovative models, and that government services and especially government services and also some NGO services purely look at mental health as a health issue. I think those are two key points I would like to make here. I know you had a lot of other questions, but maybe along the way we can talk about those.
Sure, sure. So, Soumitra, one of the things probably you touched on is there's sometimes this clash of purposes between the work which community-based organizations, NGOs are doing, and what the health system is doing. And in your experience, how is it that you can build a synergy between the two? Is it up to sort of working with some key actors on both sides so that there is a common sense of working together towards actually some kind of delivery of services which can be ensured on the ground, or is it something else? What are those factors which could be useful?
I think that if you're going to work with the government sector, the government is a monolith, and we kind of think that the government is all very planned and does things. Let me tell you that the government doesn't do things in planning in that sense, and there is a lot of different government agencies and different parts of the government almost work as if they are independent of each other. If you really want to make a difference for mental health, especially public mental health, I think the action is at the level of the states rather than at the central level. You're going to find it far easier to try and work with governments at the local state level. That's one. Secondly, and this is an unfortunate thing, a lot of the adoption of innovation in the public mental health services has happened because of committed individuals within the public mental health service. Which has not really been imbibed by the entire public mental health service. And that really worries me, because the minute these individuals are gone for various reasons, either due to retirement or death or any of these things, the system then reverts back to its original shape and form, so that no lessons are learned, nothing new is done. And you kind of have this kind of false dawn of some changes happening which then disappear off. And unfortunately, public mental health services and public health services in general in India are extremely resistant to any kind of change. Fundamentally a change in the way they work and the way they approach problems. They're happy to make incremental changes, but not change a perspective or a change of way of looking at things completely. That's the real challenge. Getting across to government policymakers, planners, for a fundamental change in the way public mental health services are delivered.
Sure. So, one of the things I wanted you to maybe also tell us a little bit around is when the mental health policy and the mental health law was being formulated, what were the kind of community mental health experiences that you looked at or tried to, draw some key components from in informing the development of the policy and the law? Were there any specific examples, and what were those kind of key components that you picked up on?
Well, I mean, one of the things that you need to remember is that the national mental health policy was framed in a way which does not normally happen in our country. So if you remember, the government appointed, the Ministry of Health at that time, appointed a policy group which actually had representatives from all stakeholder groups, not just psychiatrists and mental health professionals. It actually had a lot of NGO representation. It had government representation. It also had caregivers and users who were part of that. Now, that's a very unusual way to do it in the first time that I know of it happening that way. The second thing is that the policy group actually went around the whole country looking at a lot of services and talking to a lot of people. Anyone who will look at the deliberations of the policy group will realize that there was a lot of effort that went into it. There were multiple drafts of the policy which came out of it, and ultimately, what was put together was an attempt to try and address key issues that had been raised by various groups within the mental health community. You also need to understand that while you have multiple stakeholders in the mental health community, not all stakeholders have the same concerns, and sometimes their concerns vary from each other. Somebody who is a caregiver might have completely different concerns to say someone who works in an NGO which is providing services versus somebody who is a mental health human rights activist, or someone who is himself or herself a person living with mental illness. And not all the times that all of their concerns and interests will match and overlap. And so the policy is actually in the best traditions, I think, of how democracy should work, an uneasy compromise between trying to ensure that all stakeholders actually got most of their needs and concerns addressed in that policy. I don't think we addressed everyone's concerns. I don't think we addressed anyone's concerns fully. And I don't think we addressed difficult, there are times when there are conflicts between different stakeholders. And we tried to have a compromise in between, which probably left everybody unsatisfied. But that's okay. That's how democratic processes work, and we should encourage that.
Sure. Thanks, Soumitra. I know you have to leave a bit early, but we'll try.
Yeah, I'm going to leave at about
for...
3:45, 3:50, but I'll be around. And before I leave, I'll just drop a note saying that I'm leaving. I have another consultation at 4 o'clock, so I do have to go for that.
Sure, no worries. We'll try to come back to you for
thanks.
a follow-up quick set of questions. So now I'd like to maybe move to our colleagues from the Banyan, Mrinalini and Professor Kishore. I hope Professor Kishore has been able to join as a panelist. I know there were some issues trying to get that sorted out. But Mrinalini and Professor Kishore, if I would request you to also reflect maybe one at a more macro level on the role of civil society organizations, NGOs in a way ensuring that there is mental health available to communities. We know the challenges. Soumitra already spoke about some of them. So one from a broader aspect, and perhaps speaking to other organizations as well, which you think have played some really stellar role in this regard. But more than specifically around your work at the Banyan as well, and how can we use that as a model of thinking about how we can strengthen the capacities of communities to respond to their mental health needs, and for them to be able to actually be able to do help seeking, to reach out to health services, both in the NGO sector, but also to be able to approach the government for that. So, Mrinalini and Professor Kishore.
Yeah. Yeah, good afternoon, Mr. Anant. Am I audible?
Yes, we can hear you fine, Professor.
Yeah.
Please go.
So, insofar as mental health is concerned, we know that there are multiple people who are responsible for promoting mental health services in the community. The government is, of course, the key player. But government has its own limitations because its system has some difficulties, some resistances, and they also play multiple roles, and therefore there could be limitations. That is where I think the NGO sector can play a very important role in supplementing mental health care programs. For example, homelessness and mental health care is a very important area where NGOs have contributed in a very, very big way. Almost for 5 decades, NGOs have been the most important pillar which has responded to this need, and they have done it in a wonderful manner. The second one is the promotion of health of adolescents through the school sector for out-of-school children, and for adults with mental health problems has been an important contributor from the NGO sector. And the third important one is to destigmatize as well as make mental health user-friendly using what is called as the NALM approach. See, the conventional system approaches mental health in a manner which could stigmatize, which could shun people away from using mental health services, and that will also be a barrier to appropriately use mental health services in the rural context. Whereas using welfare as a means of increasing participation of people in the process, identifying mental distress, addressing it, and solving small problems like the citizenry role, disability allowance, and the housing issues can bring in a lot of participation from the community. And we have found NALM approach as a very, very powerful means of mobilizing the communities for mental health care. And of course, the last one is encouraging communities to do social audits, whereby the communities are able to identify lacunae that exist in the system, and these lacunae can be addressed through the district administration or the local governance, so that mental health problems can be addressed comprehensively. Last but not the least is people's initiative to improve mental health services in the form of daycare centers, rehabilitation centers in the community. In the last session, I also heard about how stigma, destigmatization can be an important issue for us, and making people productive is an important way of reducing stigma in the community. Early identification and treatment is definitely a very, very powerful means of bringing mentally ill people into the mainstream participation. So the parallel role played by the public health system and the non-governmental system is going to be very powerful to make mental health more comprehensive, more participatory, more of people-oriented things, so that mental health becomes more and more popular in the community. For all you know that there are some core issues which can be a problem in mental health. Some of these processes can be changed to bring about better participation in mental health care.
Thank you.
Mrinalini, you want to add
Kishore.
something? You're not audible, Mrinalini.
Yeah, I think we seem to be having an audio issue, Mrinalini, at your end. Maybe if you can try your microphone, trying fixing it. So while she's doing it, Professor Kishore, if I can also ask you, we're not really discussing mental health education today in any of the panels that we have, but you've taught at India's premier mental health institute, NIMHANS. How well do you think India's health professionals, especially medical professionals, are trained in, first of all, understanding mental health, and two, especially understanding a community mental health perspective? Now, of course, there might be something in the curriculum at NIMHANS which has done a lot of innovative work in the community mental health space, but I'm thinking of the multiple other medical schools that we have and the lack of exposure to mental health and community mental health for most of our practitioners who are trained there. So any thoughts on that and how we can maybe do differently?
Yeah, I think it's a very, very profound question, Mr. Anant. In general, mental health professionals do not understand the complexities of delivering care for people in the community, because this community-based approach to care is far too complex rather than delivering care in hospitals or in urban locations. And in that context, educating people to make mental health a very simple construct, making people understand mental health problems and come forward. But ultimately, whatever modules that we may develop to educate people, in fact, developing mental health modules has been part of development of medicine itself, because every area has the education component, and education component is 50% participation in medical care and 50% is intervention itself. So if that being the case, the education modules, complexities of community mental health, then the barriers to deliver proper community care, increase people's participation is a major challenge. But at least in the context of NIMHANS, every psychiatry resident spends 1 month to understand the processes of community care, the challenges that is involved, though I firmly believe that that is too small a time to spend for 3 years course in residency. The most important challenge is the non-professionals, for example, psychiatry postings to sensitize undergraduates in mental health care, identification of key common mental disorders in the community and in the hospitals continues to be poor, because psychiatry as a posting is a low priority postings in the general hospitals. And this can only be broken by emphasizing that mental health care is too important to be neglected by the teachers concerned. We are all aware that the major barrier was the lack of facilities in the medical colleges, undergraduate medical education, and so on. And now we know that out of 450 medical colleges that is there, more than 300 have received special attention to improve their resources at an investment of 50 lakhs. And I hope that the people in on ground, people in the medical colleges will have to make every attempt to see that mental health is popularized, mental health clinics are regularly held, and the power of bringing about change through intervention for persons with mental health problems have to be delivered with conviction by the teachers. And if it does not happen, mental health will continue to remain a very mysterious topic, and while it is not. The distress that people experience also has to be converted into a personal knowledge, so that an internist, an undergraduate medical student, or postgraduate training in other specialties are able to see and understand. By these processes, I think we will be in a position to improve the education component to popularize mental health care, though the responsibility lies with the teacher who is there in the Department of Psychiatry, so that he is able to show the diverse nature of mental health problem, the simplicity that can be used to identify problems, and demystification of the intervention process, Mr. Anant.
Thank you. Thank you so much, Professor Kishore. Very well explained, and also, of course, drawing from your many years of experience in teaching in this domain as well. Mrinalini, I just wanted to check in if your microphone is working. Can we just do a quick audio?
Can you hear me now?
Yes,
Perfect. Yes, can very well hear you. Yes.
Great.
So, Mrinalini, sort of building on what Professor Kishore talked about, can you maybe tell us a little bit around the Banyan approach, and especially the vision behind the Banyan Academy? How has that evolved, and what does it hope to do, and what has it been already doing, and how is it helping build support systems for community action in the mental health space?
Sure. So first of all, congratulations to Sangath on 25 phenomenal years of work. And we're so proud to be working with you, and we look forward to many, many years of meaningful association. So, Dr. Bhan, as far as mental health education is concerned, what we see as both practitioners, so the Banyan, as you know, is the service side of mental health, and we look at outreach, emergency care services, long-term care, and community-based care that Dr. Kishore has already spoken about. Whereas education is concerned, we receive a lot of interns. We also run several courses. We see that the emphasis on field work is very, very seriously wanting. He talked about psychiatry students, so I'm going to talk about social work, and I'm going to talk about psychology. There are many students in the country who cannot afford MPhil programs or PhD programs. So where they stop, and a large portion of the cohort that we receive and we work with are master students or bachelor students, right? But largely masters that we prefer. So when you look at the master's curriculum, you have 1 month of block field work, and you have 2 days of concurrent field work in the second year. This is seriously not enough. We need to look at almost a year of only field work, and that is the reality that you're looking at. Theory can only take you so far. And theory also, either it focuses on it sort of disconnects the mental health and the development experience. And 70% of our country lives below the poverty line, right? So when you have to converge the link between mental health and poverty and deprivation, which doesn't happen. So in the first year, you look and only for social work students, you look at the development experience, issues of caste and things like that. And the second year you delve into symptoms, but you don't look at any point where you converge both. And that can happen only in a separate year by itself, when there is more field work and little theory that sort of intersperses with it. And mentorship doesn't take place. So in this panel itself, we have amazingly illustrious speakers and mentors. So they need to, be sought after as teachers to work with students on a case-by-case basis, and then looking at converging all these learnings and then coming up with the theory for it, or arriving at converging theory and practice. That doesn't happen. So without a specific year allocated only for mentorship and field work, and then interspersing it with theories that we already know exist, and or theories that we need to come up with, without that level of richness in their education, we will still be wanting for a mental health professional who will speak the language and walk the talk. Yeah, so that is my
Thanks, Mrinalini. That's very very useful to know. I mean, I was very intrigued by your point around intersectionalities.
Yes.
And the fact that we need to recognize that India has a lot of diversity, but that has also its challenges around caste, class,
Yes.
religious, regional differentiations, and of course all of those also influence mental health in many ways. Can I ask you to maybe talk to us a little bit more in detail, especially when we are all doing work in the community mental health space, in all the organizations represented on this panel, and the many more who work in this space. How is it that we can make sure that we are actually responding to those challenges? Because the one way is to perhaps say that, of course there is an issue, but that is not our, part of work to work on or to focus on. We just here to do community mental health. And the other one is to recognize that these are important predictors and influence mental health in many ways, gender as well. So maybe if you can speak to some of that.
Yeah, so I mean, I will give you 2 case studies. One is of a person we heard about yesterday, who was a colleague of ours, talked about them probably having seasonal mood disorders around the time of monsoon. And, with a little bit of, deep engagement, they found out that every year her house gets washed away. So if you think that there aren't going to be mental health ramifications of becoming houseless and having to rebuild your entire life year after year, then there is something really the matter with us as mental health professionals, that we don't look at the holistic picture, right? So that is one illustration. And the second illustration is we work with irregular communities, indigenous communities, and we work with a lot of children whose parents come to us to the clinics, right? Many of these I saw one child who was trying to die by suicide, and we had a lot of in-depth intervention interaction with them. And he said, why should I go and study in school? Because I cannot sit in the same bench as my classmates. I have to sit down when they sit up. and I can't sit, I can't study with them, I can't go to their house, I'm never going to be recognized as an equal. I'm never going to get a job that I want, because I'll anyway have to work my dad's loans off, right? So in this context, when you look at child mental health, and the alarming rate of suicides that are in our that unfortunately our country is again burdened with, if we don't address these socio-economic and political and ecological determinants, we're never going to be able to achieve a holistic mental health system. And not everything is mental health, right? It is development, it is poverty, it is thousands of years of discrimination, and really instilling into people's heads that this is where you belong. So to have to undo that purely as a mental health intervention is not going to work. So as professionals, as development sector professionals, and we can't say mental health and development sector, we're all part of the same group. And so I also feel that there needs to be some mix. There needs to be mental health in development sector conversations and development in mental health sector conversations. So, and students need to be able to work together. So when you say internship, fieldwork, and practice, we need to have somebody who specializes in caste-based discrimination. We need to have somebody specializing in poverty intervention. We need to have somebody specialized in mental health and social work and mental health or psychology, right? Coming together and working as a team only. And if we don't do that at the education level, how are we going to be able to do that when we implement once they pass out? Right? So we need to recognize these, we need to recognize the divide and the chasm, and work together right from the master's level or the bachelor's level. So whether it's faculty or students, we need to come together and resolve a problem as one unit. And that's when we will know, and that transdisciplinary approach is what will take us the distance. Otherwise, we'll always be working in departments and in silos, and we're not going to be able to come together.
Thanks, very powerfully and very well expressed. Thank you so much, Mrinalini. So if I could now move to our next speaker, Sadam. Sadam, hopefully you're able to, yes, hi, I see you. Thanks for joining us, Sadam. Good to have you. Sadam, we already have been now discussing in this panel issues around intersectionality, and you are someone who is a young person. You have of course, set up a team of young people like yourself at you all in Manipur, who are working on driving awareness around mental health, especially for youth who identify as LGBTQIA+, and also to provide mental health services. So can you maybe tell us a little bit around your own experiences of working with communities, working with young people who are often marginalized and responding to their needs?
Yeah, thank you, Anant sir, for the question. And hello, sir, Soumitra sir. And definitely, my journey into mental health, and our journey in mental health activism, and as a group of young people from Northeast, is mostly because of the way how the people from Northeast have been left out most of the time. And when there are platforms to share about work, when there are very less opportunities for even elder people to come in and share their opportunities. And I'm a privileged person in this way that I'm able to share my own share my own experiences and the work that we are doing here. So mostly, even for YAOL, that it's a very young organization and also led by young people. It's just been 3 years, and out of these 3 years, 2 years has been in COVID. So that has been one learning from us, where we lost our workspace. We, in this time, we totally run on crowdfunding, and somehow on the way we got some fundings from there. So the biggest challenge for young people and also for younger organizations and people in the margin, like the Northeast, the biggest problem is access to resources. Even if you see the entire Northeastern region of 8 states, if you find out, are there any healthcare facilities for mental health? I think only Assam has one for all the entire region. So that is how mental health is treated. So even in Manipur, there are no facilities properly if it comes to mental health, and they only have a department if it's in the hospital. But what about young people? What about people who identify themselves as queer or people living with HIV? They do not access. Like, for example, for me, I also identify myself as queer, and also, have been into substance dependency and overdose and overcame from it. on my recovery. So there was a lot of problem which came. And as Soumitra sir was saying, that there are so many social determinants that defines one's mental health. So my own lived experience of how, as a person, queer person, and also from Manipur, and finding a voice, and also dependent on substance, there was multiple barriers on the way to access to help. So we didn't get help because one was people didn't know about the intersections of sexuality and mental health. People didn't know about the conflict and mental health. People didn't know about migration and mental health. So they didn't. They wanted to understand it in different aspects, but they didn't want to intersect all these things. But as a person with lived experience, it intersected all in my own life, and that's how Yaol came up as a support group, as a safe space for young people, because I almost tried to access all the healthcare services in Bombay while I was struggling for recovery, and I didn't get it because no one gave me that space to totally express myself as who I was, either from my sexuality angle, or either from the mental health angle, or from the migration angle that many young people from the Northeast face when we come to the mainland part of the country, because people generally uh, always treat us as others, like from the other part of the country, from the Northeast part of the country. They don't know much about us, and there are always the casual angles of racism that comes up every now and then. Biggest example was during COVID. What happened? People from Northeast were called Corona. They were thrown out from jobs. They were thrown out from schools, colleges, from everywhere, and they were spat on in some cities of of COVID also. So there are so many things that there are so many issues that intersect, and no other organization or no other people were talking about this. This whole intersection of racism, migration, mental health, substance. Manipur stands second in HIV prevalence in the country. It has 1.4% of people living, of every 100 person living with HIV. So and also it's in the border state. It's one of the border state towards people who towards the Golden Triangle, with lots of substance dependency and also lots of smuggling happening. So people generally do not talk about all these things. They don't acknowledge these issues. So that's how I, as a young person with lived experiences, I don't have any degree. When I say in mental health, I don't have a degree as a professional, but we started working because it was the need. It is the need, and that's how we have come up till here, mostly based on evidences and not on numbers. Because when people ask us for data, they always say, how many people are there? We say, we know there's no data at all because we don't even have a mental health proper center here. So it means there are no data and people treat us as like we don't exist at all. So that's how we are starting with evidences. Like I am evidence. My story was the one which started Yawal, and now many young people are following up because they could relate to relate to my story, and there are so many stories like this which were never acknowledged by many people. And that has been the journey of how Yawal came up and how Yawal is working as a safe space, as a peer support unit, in the Northeast. And we definitely feel there's more to go from here. It's just a starting. Yes, sir.
Thank you, Sadam. And first of all, let me acknowledge the very, very important point you made, which is, for us to recognize lived experience as a form of expertise, and that people who share their experiences should never be shunned in any way. Their experiences should count. So even if we keep those of us who wear the researchers and the policy hats keep chasing data and numbers, it's very, very important for the voices of people like you who are leaders in this domain to be heard and to be responded to. Sadam, you talked about, and you've been very vocal about the fact that you had mental health crisis when you in your time in a city like Mumbai, and the system there perhaps failed you. So what do you think you are trying to build with your colleagues, which would be different, so that you could be able to respond to their needs? And two, how can all of us, the rest of us on this panel and the many people listening in, what can we do differently so that the needs of young people are responded to, especially those who are marginalized?
Yeah, one thing which I was searching everywhere in Bombay was somebody who could listen to me without any judgment. It looks very easy. It looks very easy, but it's the most difficult part. Even in Bombay, where every street has a hospital or some sort of clinic where you can seek any form of the place where I was in Bombay. The biggest challenge was they when I go to a mental health professional, the first thing they will sit me for 10 minutes and they'll start writing medicines, prescriptions. So it was mostly based on prescription, and those prescriptions did make me sleep. Those prescriptions did make me feel better for some time. But for me, that was not the thing. There, when I was wholly dependent on substance and was overcoming from addiction, the biggest challenge was that they were trying to treat the substance out of me. They were not treating me. They were not talking to me, but they were talking to the substance and how to get out this substance from this boy. So that was the biggest challenge. So they never told me to share my story. They didn't give me, half an hour or 1 hour to set me down and made me relax and talk what are the issues that Saddam is facing. So there were different structural barriers. One was definitely the othering was always there. This is something which people might not acknowledge, but I always bring racism as one angle which others us even in healthcare settings. When it comes to LGBTI individuals, another challenge is that when you are sharing that story, the problems that you are facing, you are hiding one part of yourself to that professional because you are scared that what if they, judge you, or that is one big component that stays there, and that's why many people do not access healthcare because there are so many traumatic experiences where people go to a service center and they are scolded at, they are trying to be corrected of why are you like that. So many young people are afraid to go to healthcare centers and they don't seek healthcare services. That is one big reason. See, for example, when one person is going there for seeking mental health condition about a same person like me who are depending on substance, one component was that substance use is illegal. And when I say that I'm using substance and I'm using a substance, there might be a police case, which happened in case of me. When I was hospitalized, the hospital said that, until the police case is filed, we will not let you in. So a police case was filed. A policeman came in the hospital and was sitting on my bed and asking me, like, from where did you get the substance? So that is the kind of way which I was treated in Bombay, in hospitals, by the police. So that's how I don't want that to happen to people. Hospital or medical health systems should be spaces which are safe. It should not be a spaces where a policeman comes in and start asking you what about the substance, about this thing when you are trying to overcome the trauma. So when I'm building YAWL, I'm building YAWL as a space where we can listen to anybody. We can give 1 hour, we can give 2 hours. It's a space where we want to listen to young people because that has been the biggest challenge that nobody wants to listen to us. So we are giving that platform and we are opening it up as an inclusive space where it can be accessed by LGBTI individuals, it can be accessed by people living with HIV or psychosocial disabilities or orphan. So many people in the margin. So that is one which we have been able to do, and mostly these are what I always say that these are lived experiences, and when I bring out this in number, it will be very few, and people generally don't think that it's not enough. If the sample size is too small, but for us, one person like me starting YAWL, it has created enough ripples in my region, and I think that if we can bring out more evidences, that will create a bigger wave. That's the work that YAWL is doing in gathering evidences mostly. Yeah.
Thanks, Sadam. Thanks. Very, very good to hear about the very, very, very well required work that you're doing, but also the leadership and the community that you're building of young people who are taking a lead in this domain. Soumitra, I know you have to leave around now, but I know that you also had raised your hand. So before you leave, one, can you perhaps maybe speak more to the point that you had put in the chat? Because I think that's an important one to hear from. But before you leave, if I can also ask you to maybe speak to us around the fact that now we are all training this whole new cadre of community health volunteers, workers, functionaries. There are different models in each of our organizations. But then we are also expecting them to do a lot, right? But so how do we also build those enabling systems to support their needs? These needs could be one of training, supervision, hand-holding, monetary needs, but also their own mental health challenges, because it can impact your mental health when you are having to support a whole lot of communities where there is no mental health, and it brings its own stressors as well. So maybe if I can ask you to both speak to your comment that you wanted to make in response to Mrinalini's points, and also speak to this issue before you leave. Thank you.
Well, I'll try and address your question first. I think that organizations which are setting up and running these kind of programs in the community, where we use whatever different terminologies that we use for them, community health workers, volunteers. I think these organizations have a moral and ethical responsibility that they are provided with the support, mentoring, and supervision for whatever work they do. I think organizations can't just say, well, we've trained you and thank you so much, please go out and do the work. That I don't think is even ethically a responsible way of behaving for NGO organizations. The other thing is that mental health needs need to be, first of all, acknowledged and addressed. And I know that in the government sector that does not happen, but I also know that very often in the NGO sector that is not acknowledged, that's not seen as something that needs to be addressed. And I think we all have an ethical as well as a moral responsibility to ensure that these people who are doing this work get support. I frequently come across organizations which will say, we want to get into the mental health space. Can you train our community health workers to do this work? And there is this impression that once they are trained, they can go out and do the work, when they don't get any support or mentoring or any kind of supervision. That's just unacceptable, according to me. And I think every organization which sets out to do any kind of work in the mental health space in the community, using community health workers, volunteers, needs to actually put that entire safety net in place for the people they're working with. And without that, you can't just be running a mental health service, And to turn to the other issue of caste, I thought Mrinalini made a very important issue, and I did talk about intersectionalities earlier too. And Mrinalini is just emphasizing the same point about intersectionalities. And what is very important is that while we talk about intersectionalities, especially when it comes to caste, it becomes very stark that we have a lot of well-meaning people who come from upper caste, or I hate to use the word upper caste, but come from a caste background, who then very well-meaning and obviously concerned people, who then speak up for the whole issue of what is faced by people from the Dalit, Bahujan and Adivasi communities. And while that is very good, I think it's extremely important that those communities are provided the space to speak up for themselves. Lived experience is not something that can be explained secondhand. That's one. And secondly, for all practical purposes, and this is a very difficult thing, and I know people will hate me for saying this, but for all practical purposes, in every NGO or most NGOs and in the public sector, the mental health leadership is all upper caste, or is all Savarnas, is all caste people. Where are the Dalit, Bahujan and Adivasis in the mental health leadership? It's paradoxical. They are there at the workers, the community. If you go to every organization, the community health workers and the volunteers and everyone will be from the DBA community, but you'll not see them in the leadership. And that again is just another form of caste discrimination, which I think we as organizations need to be aware of. So I'm very happy to see someone like Sadam, for example, speak up for lived experience from a community that he comes from, and to be part of these kind of not only programs but also discussions around mental health. But the same thing needs to also happen when it comes to caste, for example, because caste is the big elephant in the Indian room. Everything else is probably tiny stuff, but caste is the big stuff, and it also directly impacts the poor. I mean, if you're talking about people who are poor, then they're likely to be from the DBA community. So you know, the intersectionality of caste with many other things is so high that we just ignore it completely. Yeah, sorry, I just a little bit of a rant there. I need to leave, Anant. I have a 4 o'clock call, so I'm off now. Thank you so much. Thanks for inviting me. Best of luck, and we'll be in touch.
Thank you so much, Soumitra. So that's an important rant to have, and I'm glad that you brought up the issue. I think it's actually, you know, it's a good inflection point for all of us, as you pointed out, including for Sangath, around the fact that, you know, how do we look at our own leadership, the next level of leadership, and ensure that those who are impacted the most in terms of the various stressors and the intersectionalities are also reflected. Professor Kishore, I see that you have your hand up, but if you would just allow me to get our colleague Bindiya in for our introductory remarks, and then I'll come back to you. That'd be fine. Bindiya, thank you for joining us. Also great to have you as a Sangath colleague in this panel. So Bindiya, you've now been a counselor, a trainer, a supervisor for many years in the counseling space. So I would like you to maybe share your respective perspective as a counselor and trainer. You know, what has that involved, especially working with the diversity of populations that you've worked with for many years, and what have been the challenges? But also, you know, what do you think we need to learn from that diversity of experiences? Perhaps as someone who represents counselors and supervisors of counselors, you can speak to the perspective of that set of professionals and inform the rest of this panel and, of course, our audience as well. So over to you, Bindiya.
Thank you, Anant. Thank you for the introduction. Good evening, all. Yeah, so I think so. You have briefly covered up about my introduction, but going through my journey for this past 15 years. So I joined Sangath in year 2006, and I have joined with the project called as Manas, which was for stress and depression. And from there, I have moved on or grown into the role of intervention facilitator or trainer and a supervisor. So when I joined, I knew about mental health, but however, over these years, the understanding of mental health has deepened. So working with various population, adults, children, and even with mental health concerns such as stress, anxiety, depression. So this knowledge has been vast, and it has been expanded from where I joined till date. So I have not only learned intervention or strategies that work upon improving mental health, but also I have used them personally or personal life as well. So basically, looking at the delivery part or the capacity building of the lay health workers. So I think so previous panel, there were a lot of discussion going around about stigma. And if you look back 10-15 years ago, people in our community, I think so it's almost everywhere, they knew they had this stigma attached about mental health. And this was the biggest challenge. The challenge was to first get people know or understand that there is something more than physical health. So in Goa here, the most commonly used word was pishe or nervache or mental, which literally means like mad person. So this was the term used, and it was stigmatized. And there were various factors, various challenges to adhere to the treatment or the intervention what we deliver. So what was important here is to understand that one can access mental health services, and Sangath is an organization which tries to bridge the gap between community and mental health services. So the primary focus here, what we do is creating intervention or tailoring intervention, which can be helpful within community where mental health services are not present or difficult to access. So me being part of the community mental health worker or a counselor, so the community, they being part of the community, they try to accept you, relate you, they try to speak about, or speaking in the same language build trust, or the rapport is created where the process of delivering mental health or interventions or counseling is much easier. And also with this aspect in mind, sometimes delivering an intervention has its own set of challenges in terms of as a counselor. So if you have proper training, there are refreshers, regular training sessions, which are closely supervised with the systems that encourage quality training or supervision. There is supportive team who supports you not only on field in office, but there are, if you have any other difficulties, we can definitely have more people like me who can drive an impact to improve mental health in communities. And these all aspect has helped me to be a counselor and supervisor overall. Yeah.
Thank you, Bindiya. That's very useful to know. What are your thoughts on how we can leverage lay health counseling to respond to community mental health needs? Because of course, you can have the model where everything is dependent on psychiatrists and psychologists, but we know there is an acute shortage. They're not available in all regions. They might be largely concentrated in urban India, for example. So how can we work with a model where we also have lay health counselors, especially those who are community facing, helping to respond to India's mental health needs?
So I think so. So I think so. I have already spoken with proper, good and clear training programs, and also refreshers, training, the good supervision model. So this could be helpful. Like supposing as Dr. Soumitra was mentioning that only giving training is important, but keeping on constant check about new training them or any refreshers or good supervision model after training, how the session how the counselor has been doing the session. So these supervision models, supportive teams are really important. It plays a important role.
Sure, Bindiya, you've now, as you were mentioning, transitioned over various roles. In your opinion, who is the right fit to be a lay health counselor? Are there certain aspects of what kind of a person you should be choosing for that role? For organizations and programs which might be looking to initiate a training program to build capacity for lay health counselors in their field areas, who are the right kind of people they should be looking out for who can become lay health counselors?
So some basic educational qualification is required. So maybe graduate in any field. These are the main important, the educational qualification, and you can train these people based on the intervention or the population you're looking at. Supposing if you're looking at the population or you're training them on stress or depression. So maybe, the proper training program, the structured training program, the assessment and everything, if these are in proper place, you can train anyone.
Great, thanks Bindiya, good to know. So that's also encouraging that you just probably need some basic education qualification. I know there are actually some programs probably who also work with anyone in the community, as long as that person is committed and interested in delivering care. All right, so I'll maybe go back to Professor Kishore. You had your hand up and you wanted to maybe add on to some of the comments made by a previous panelist. So if I can ask you to perhaps again, tell us what you wanted to talk about, and then we will have another round of follow-up questions for all of the panelists. Professor Kishore?
Dr. Bhan, so Dr. Kishore also had a 4 p.m., so that's why he had his hand up. But I know what he wanted to talk to you about. Sure. He called me. So, you were talking about intersectoral collaborations and, the role of government and non-profits, NGOs in the mental health milieu, right? So what basically we wanted to say was that there is no either or. in the development sector and in mental health. We have to have multiple players, equally invested with different kinds of roles that they need to play, so that we will not put the burden on one system and cry about it when things aren't working, essentially. So we are actually working with the government of Tamil Nadu to scale up our emergency care and recovery models in 13 districts in Tamil Nadu. So we work in the district hospitals itself and create 20 to 30 beds exclusively for homeless people with mental health issues. So it's like a public-private partnership, similar to what we do with NULM shelters. And I know Ishwar Shankar also does similar work. So this way we have multiple partners coming in and equal ownership amongst each. And we play the roles that we are meant to play. We look at individual care plans. We look at, nimble pivots that we need to make with regard to certain changes in the system, and with regard to certain changes in the client's life, which may not be possible by the government, whereas the government provides us with the infrastructure which we avail of, which will be additional cost for an NGO that we cannot simply afford or sustain. Right. Similarly, we are also working with the government of Gujarat, government of Kerala and Maharashtra to scale up Home Again, the Home Again initiative, which is long-term care through inclusive living options for persons with varied levels of disability. So we are not always going to be on the same page or see eye to eye, but I don't think it should be either or. It has to be collaborative, and and education also needs to play a role here. For-profit entities also need to play a role here. Philanthropies need to play a role here. And only through models like this will we really be able to demonstrate that each person has a role to play in the sector. So that is what Dr. Kishore wanted to say. And in response to Soumitra's question, he's not here, but we are working with the Safai Karamchari groups, to promote leadership because they also wanted to look at mental health interventions. But again, if you see the history of history and even present, the situation that they're facing, and we have to look at promoting leadership there, and they already are incredible leaders. So we don't need to say we need to teach them mental health, but it needs to be a sort of two-way leadership, wherein they come in with what their expertise is, and we come in with what our expertise is, and we sort of work together. Again, so the leadership happens only, leadership and these collaborations happen only when you have a specific common vision in mind and a roadmap and specific roles that each person has to play, right? So that's what we wanted to share with you before Dr. Kishore had to leave. So yeah.
Sure. Thanks, Mrinalini. Thanks for perhaps speaking to the point which Dr. Kishore wanted to make. So, Mrinalini, while we still have you, one of the things I wanted maybe you to speak to us about was that, as someone who's worked in this sector, who works with the Banyan, who has seen many other civil society organizations and NGOs which work in this sector, what would be your thoughts around what do all of us need to do? What should be the kind of priority areas for all of us to work in our own organizations to respond to the evolving mental health needs of India's population? And, as organizations, how can we also evolve? So we already talked about, for example, the leadership and the need for diversity in our leadership. But what are the other kind of things that you would like to see in this sector happen?
Well, that's a loaded question. So I think it really depends on the organization's priority, but it also depends on the geography, right? Because without doing complete justice to the locality in which we work and the specific problems of that locality, and using multiple stakeholders, whether it's panchayats and in urban areas, you may have, you may be working with the corporation, the municipality, right? So I think bring the community together with the priorities that they feel need to be addressed, both through mental health and through other forms of aggregated oppression, and really identifying a model that can be sustained, right? So whether there is this one village one project program for livelihoods that has been developed, and they look at, one village looks at only producing oil because that is their strength. One village looks at only producing honey, for example. So we need to really go hyper local and identify what issues within the specific communities need to be addressed, and not go in with our own preconceived notions. right? We can bring in our expertise in terms of systematizing a particular program, but the soul of the problem and the soul of the solution really lies within the community. So I think we just need to go hyper local and understand aggregated oppressions, what are the expressed and felt needs, and work towards that vision, is what I would say. Yeah.
All right. And in terms of networking, do you think we need to have a stronger network
Much
of
stronger.
community-based organizations? And how do we make that happen?
So I think that, you know, I feel we need to go more vernacular, because again, the conversations that we've had today are in English, right? We need to do a Sangath celebration in Hindi. We need to do a Banyan celebration in Tamil and in Malayalam in Hindi. So I think that so much of nuance gets missed out, because it's again only a couple of us that, you know, that speak. While I may represent 400 people that I work with, I would still like to, I still don't know if I'll do complete justice to what some client of mine with lived experience who can only speak Tamil can do. So I think that, you know, we need to break up into smaller groups and get more vernacular insights and vernacular wisdom out there. And then, you know, we look at translations and other things, but otherwise it's a small incestuous group that keeps speaking to each other. Right. So we need to go local. We need to go Tamil, Hindi, English, Malayalam, Bengali, whatever. So I would feel that is an important next step.
Great. I think go local, go hyper local, go vernacular. Great points. All right. So I'm going to go back to maybe Sadam. Sadam, you know, I think you're still there with us. Sadam, you spoke about two aspects which I think are relevant. One very relevant in the sense that you know, you bring in those unique perspectives. One was around this whole issue of racism and the fact that perhaps we don't have open conversations about that in India. That there is a significant section of our population which is treated in a manner which marginalizes them further, which you know, which is clearly because of a domination of a certain perspective of what it means to be an Indian. And the second thing, of course, was around your own identification of issues which are specific to young people and young people who belong to the LGBTQIA plus community. So what are some of the gaps that you have identified that you are trying to now respond to, and which you would like the rest of community-based organizations, NGOs on this panel and beyond to respond to, so that we do better in that domain?
Yeah, mostly the gap everywhere is because people are ignorant. People, they are very comfortable in their own zones of work, so they don't want to have any extra effort to bring out the change, because an extra effort means a lot more resources. So you have to mobilize for the resources. You have to, you know, run around for that. So in a very simple language, that is it. Like, you know, so for example, when we even like as a community person, as a person with lived experience, if I say that I really want to do this thing in Manipur, but the legalities doesn't allow me. Like I don't have ATG, I don't have 12A, I don't have FCRA. So you know, these are the legalities. Even if I want to do a lot more things, I cannot do it because yeah. Sorry, the current went off.
That's okay.
You can hear
Go
me
ahead.
again.
We can hear you. Yeah. Go ahead.
So that is the thing. Even if I really want to do a lot more thing, because of all these legalities, we cannot do. That's why we are fundraising and doing a lot of things. We do get small grants, but for a mental health intervention, small, you know, short duration grants doesn't work at all. That I think everyone knows. And mostly as a community, and if we have to say from the angle of racism, is that people have acknowledged that there is racism, but they have not made it a priority to make it go further, because the population that we are from the Northeast are still, you know, considered as something which is not important, frankly, to until we bring a medal in Olympics. Where everyone celebrated Mirabai and people started talking about Mary Kom, but the next day people forgot, like where were they from? So that is the same thing of the superiority and inferiority complex. If you know it's there, it's there. People might say it's not there, but it is there. Like when we go out to another bigger city, when we are called, are you from China? Are you from, Nepal? Are you from other places, but not India? But when we say we are from Manipur, they would say, oh, where is that? And this casual question of, is it safe to go to Northeast, or like, is it, a very casual thing that happens, do we eat dogs, even in our food habits, or how we stay. So people have so many questions regarding our lifestyle. So we are looked at as a specimen which is inferior to the dominant, population in the country. So that's why people, because most of the, like Soumitra sir again was saying, that most of the people who are working in organizations heading CSR, everyone are from the mainland part of the country. So until and unless they acknowledge this fact that there's a lot of diversity and we need to go beyond this, then there will be no resources. Like exactly, we do not have resources. We depend on funding. That's a very sad thing. So even when Mrinalini ma'am was saying that people have to go hyper local, one village, one project, everything. But what if we can't access the resources to start those things? So we don't have CSR, we don't have companies, we don't have big organizations in this region. So all these resources come from outside. In a recent study report, we realized that the whole CSR spending in Maharashtra only was much more than the whole 8 states of Northeastern region. There's a lot of inequity that is happening even in the CSR spending, or even in organizations supporting other organizations in this region. So we can definitely say there are numbers for that. There have been many reports for that, but people generally prefer to work in those regions where they can when they can physically go and provide support. So we are left out in any crisis, and further left out because we are from the community, and because it's a whole lot of trickling down mechanism that happens. Like we always look up to the center because that is the only godfather that is there, because this central funded programs or state funded programs are the only option when there are no CSR. So as a young person, or as a game, and as a survivor, we all know that this region needs a lot of effort, extra effort, if we have to leave no one behind, and if we are working towards sustainable development goals. Like people are talking about climate change and gender, people are talking about a lot of things, but the basic thing of acknowledging us as human is not there. So that is the first thing which people need to acknowledge, and people need to look beyond their comfort zones. And when they say look east, they just look till Kolkata. We are northeast. You have to cross a whole lot of country of Bangladesh to reach the northeast again. So people's sight is only till West Bengal. They have to go beyond that. When we talk about northeast, and when we talk about northeast, people's idea gets stuck with Assam only again. So there's a lot of diversity is there. So we have to first things to acknowledge that these are our own people. Otherwise, the self-determination movement that has been prevalent in this region, it gets stronger because we are further left out in healthcare, education, jobs. Many people, young people, migrate outside for better education facility. No job here, so they go out for security and so many things. And when we go out, that time only we realize that we are looked down. Like we face racism. That only we realize. Even for me, I realized when I was hospitalized. I realized when I went to seek a service. So until and unless it happens to the individual, people do not know that such things can happen. So that is the point that I really like to make. Yeah.
Thanks, Sadam. No, this is important for all of us to hear. Anything from casual racism to marginalization to being excluded to being looked down upon, all of that, of course, just are important things for all of us to think about. That why is it that that is still the case? Why haven't been able to be more inclusive? And of course, the impact that will have on young people, especially who are migrating out, who are interacting with other citizens from other parts of India, and feeling that there is this constant effort to put them down. So it's something certainly to think about. Bindiya, maybe building on that, how can we ensure that when we train our lay health counselors, when we train our health providers, that they are made sensitive to these issues, so that when they actually provide care, they are able to do that in a manner which is respectful, engaging, which recognizes the need for understanding inclusivity and diversity. Do you have any thoughts of, as someone who's also done trainings, as someone who's done supervision, how do you ensure that counselors who you work with are very respectful of the diversity of clients that they might see?
Yeah, so here the training process is involved, like, taking them through the basic core counseling skills where, they have been taught of how to not being judgmental, how to respect whatever the person is talking about, how to listen to them. So this is more important, and this is done through training and, a lot many refreshers. And if they face any difficulties, there are peer supervisions, there are supervisions where they can bring these difficulties during these meetings and discuss. So this is important, like, we stress, there are case examples discussed, there are role plays before implementation, like before going in the field, there are role plays, how taking different scenarios like this, how to not be judgmental, how to listen, how to respect other people's. So this is more important. So this is done during the first training.
Great. So, making sure that this is a very integral component of training, the supervision process, ensuring that there is demonstration, there is role playing, can perhaps help us make sure that the counselors that we are training are more keyed and prudent on some of these important areas to work with. Mrinalini, if I can go back to you and ask you that, given what you have seen and what you've heard, what do you think in this field of community mental health have been the most successful strategies in promoting mental health, and how can we ensure that some of these are scaled up if they have not already been scaled up? The scalability question, because I know you talked about the fact that we need to go hyper local, but for impact we also need to talk about scale. So how do we build a momentum for community mental health that we are able to reach scale?
Yeah, so the strategy that we've adopted is going through the education route. So we offer 6-month diploma courses for community mobilizers on mental health, community-based mental health and integrated mental health care, essentially. And the topics that we cover, like I said, look at mental health from a development perspective, the interlinkages between poverty, intersectionality, and things like that. So we train community mobilizers, and not just in Tamil Nadu. We completed a course in Sri Lanka. We're completing one in Bangladesh, and we're doing a training of trainers program. So if we identify local leaders, whether it's from panchayat or self-help groups, or like I said, with the Safai Karamchari groups that we're working with, we train, and then you initiate programs there that, that where you promote referral, identification, and follow-up, and long-term care that are also trauma-informed, right? Because that is clearly something, especially when it comes to caste or sexuality-based, gender or sexuality-based discrimination. So to look at ultra-vulnerable communities, which is what we refer to them as, or subaltern population. So working in, with them, and, creating a sort of inclusive model in mental health, bringing in all these collaborations. Well, the template is the same, right? In terms of, this is what we're going to teach, and these are the people who require additional support. After which, the program becomes scalable with the government, because you already have the human resources that are trained to take your vision forward, right? So we are taking the education route, and it's worked pretty well for us so far.
Great, thanks, Mrinalini. All right, so I think we'll open it up for a few questions before we hand over to the next panel. Mrinalini, there was already a question earlier when we were speaking for you and the Banyan team, and this was around the fact that the TIS Banyan collaboration has developed this great model of training and supervising master students in psychology to work with clients. So which is very sort of practical and practice-oriented, client-centered, etc. How can we take that model and apply that to many other universities which also offer courses in psychology, so that these courses become more practical and supervision based rather than being very theoretical as they might be right now?
Absolutely.
And while, yeah, go ahead.
Sorry, you were saying something.
No, I was just going to encourage anyone else, if you have any questions, kindly please make sure that you put it up in the Q&A tab so that we can get to this. Yeah, please go ahead.
Yeah, so that was again our emphasis on field action. So the masters with Tata Institute, the Banyan and Tata Institute, we're entering into our last year of collaboration. We're looking at other ways to go about it. And like I said, we're focusing more on community-based community mobilizers and more vernacular courses, right? So to build local leadership. So the only way to go about it is to give as much importance to theory as we give to practicum. So my suggestion would be to make it a 3-year master's, and I've been saying this for a while to practically every educator I know, to say to make it a 3-year master's course. And I mean, and it can be like an honors course where you have 2 years of somewhat theory, and in the second year you merge mental health with development, and in the third year you make it an entirely mentorship, fellowship oriented course with a lot of jumping into the field and identifying issues in the field. And 1 year I think is good enough time for you to understand field realities. 1 month is not, right? So so my plea to educators would be to make 3-year courses, so that you allocate 1 year entirely towards mentorship, entirely towards field action, and using case studies to enhance your knowledge and enhance your wisdom, which is more important than knowledge in many instances, to make a difference in the sector and to call yourself a really robust and inclusive mental health professional.
Sure, thanks, Mrinalini. So hopefully some of the colleges and the institutes which offer these courses will be listening in and will take heed to that practical advice. Fingers crossed, indeed. Sadam, I want to go back to you. I know there are challenges with foreign funding, which you talked about, FCRA, etc. So let's maybe imagine that there is a few Indian funders who are listening into this conversation, either live today or hopefully when we put it out there on public platforms. What is it that you want to put out to these in terms of the needs of young people who are marginalized, and the needs for also young organizations like yourselves, which are fulfilling an important need in an underserved area? What is it that you want to tell them needs to be done better?
Yeah. So sorry that current went off and
No problem.
like it's dark. So one thing that which I really, I when I say this, people, they laugh it off because they support me in one sense. But I say that even most of the organizations that are working for young people are not young. So sometimes there's a lot of generation gap that happens, and within those generation gaps, the problem is different. It's very different. Like what we are experiencing here is totally different than what other people used to experience in their time. Like some years back, there was no internet and there was no issue related to social media or internet consumption. But now there's a lot of mental health conditions, which are related to the internet and social media. So the issues are different, and also young people's perceptions are different. For example, when the biggest challenge for us has been, for us and also for many other young organizations, has been fundraising, because like resources. Because even if they are willing to work, that is the biggest factor. Like how long can we work with, by collecting money from others? Like we may work for a year, but after that, it's no, we cannot move further. So if people are saying that they really want to support young people's work, or if young people are now campaigning for diversity and inclusion as a campaign altogether and starting DNI initiatives in every firm, then I really question them that, are your DNI firms really inclusive? That you are not even acknowledging. No, they are not even acknowledging the people. They are not even giving us opportunities or platform to share like this. Like I have been with Sangath for last 2 years and been associated somewhere in our project and program. So these are the platforms that we really want. Otherwise, if we don't get such opportunities to speak up, then how will people know that such issues exist? And people will even not know how many Sadams are there. Because Even for me, I'm a privileged person because I stayed long in Tata Institute. I'm a student of this, so I got to know about all the issues, of all the intersectionalities, and I could apply it in the field. Like Mrinalini ma'am was saying, a lot of field work is needed. So that was my field work. Yet when I came here, I saw there were so many problems. So Yawal itself was a field work. And that's how we started building up the work from the community itself, from the grassroots itself with lived experiences. But again, the biggest problem is, we can do a lot of work on evidence gathering. I definitely say, even if funders are not able to find numbers or data to show, we can definitely do a lot of work around, evidence gathering in the region. We can do a lot of work around starting very new things, because Northeast is a very young, very, a virgin place for many researchers. People see it only as a natural beauty space. But more than that, there are many issues which can be done in terms of healthcare, in terms of mental health or sexual reproductive health that we are working. The biggest challenge was that, when we started working, there were so many issues that we didn't know from where to start and which issues to drop. So when we started working on gender and sexuality as a support group, but afterward we started including mental health and started including sexual health, reproductive health, it became bigger and bigger and bigger. So there are people who are seeking help. So we are people who are seeking help. The only thing is that please listen to us. Please give us platforms so that you can also learn about us if you really don't know about us. So being ignorant is no longer a bliss, I should say. We can do more. So that is the only thing I should say is, like, please listen to us, give us opportunities, let us share our stories. If you don't know, learn from us. There is nothing like, one cannot learn from a young person. Definitely one can learn from a young person also. So let's change that mentality of young people are not meaningful or young people are not accountable. We are accountable. We are more spirited now. So we can do a lot. We have a lot of passion. So definitely let's work together. We are here. If somebody wants to work in the Northeast, we are here strongly. So I would love to connect with many people. Thank you, sir.
Thank you, Sadam. Very clearly expressed. Young people are accountable. Young people are here. Young people are reliable. And organizations like you all are there who are doing some really interesting work. So if you know of programs where you could collaborate, where you could help support them, fund them for expanding their reach, then please do it. All right, we are at the cusp of the transition hour, and this is when we will be handing over to the next panel. But before that, I do want to, on behalf of Sangath, on behalf of the audience, thank very, very much our panelists, Soumitra, Mrinalini, Sadam, Professor Kishore, as well as Bindiya. Thank you so much for joining us and sharing your perspectives. It certainly enriched the canvas of the discussions that we have had, and we've learned so much. Hopefully, a lot of these messages, a lot of these points will stay on with and be important inflection points and reflection points for all of us. Thank you for joining.